Good morning. I'm here all by myself again. I don't know about you guys. I'll cut those of you some slack that have a Friday clinical. All right, so I'm just going to do a quick ECG review, even though we don't have a test Monday. So don't forget that. It'll be the next Monday. But I thought I would go over a few things to help you study. So here's your normal ECG reading. Just remember that your P wave is your atrial depolarization, and your QRS is your ventricular depolarization. And so you can see right here, I'll change colors with my little pointer to green. So P wave right here, that's your atrial depolarization. QRS, that's your ventricular depolarization. Your ST segment is it's getting ready to repolarize. Okay, so ST segment isn't anything except the heart getting ready to repolarize. And the the ventricles repolarize right here on the T wave. Then it rests and is ready to depolarize again. You have your isoelectric line here. Anything above and below are deflections, positive and negative deflections. That helps you decide if your ST segment is coming right back up to your baseline. Excuse me. Or if it kind of sags and kind of hangs out a little bit and you've got ST depression, or if it kind of shoots up here and then has your T wave with some ST elevation. Steps to interpreting, remember with your rate, too fast, too slow, or just right, you want it in your 60 to 100. Your rhythm, whether it's regular or irregular. And when you're looking for those irregularities to see if it's overall irregular or if you just have early beats, make sure you look for that PQRST little package that looks exactly the same and count your regularity from there. With your P wave, that there's one for every QRS, that they look alike, nice and round and upright, and just one before each of those QRS complexes. Your PR interval should be 0.12 to 0.2 or constant. So we said mostly in class unchanged, changed or unchanged. That would be the same as constant or inconsistent, I guess, consistent or inconsistent. QRS complex is narrow, less than or equal to 0.1, or is it wide? ST segment elevated or depressed, and your T wave inverted or peaked. If you walk right through your strips just like that, you're going to be able to identify each of the pieces. I would say after the T wave, and I kind of forgot to put this here, so right down here, your little X, is to say, what are my early beats? Because you might identify up here in your rhythm that you have a regular rhythm, but that you have some premature beats. So down here after the T wave, you want to make sure you identify your premature beats. All right, so on this first slide, let's see here. I don't know if I can get it to look any better for you. Well, maybe not. Hopefully it's good. So you have what's your rate? So we have 1, 2, 3, 4, 5, 6, 7, 8. So it's 80. Then you have what's your rhythm? From here to here to here. Looks very regular, right? Then we want to look at our P waves. Do we have them? Yes, we have them. Do we have one before every QRS? Yes. Are they looking alike? Yes. And is that PR interval relatively unchanged right through here. Yes, it is. So then we have to look at our QRS. Is it narrow or wide? This particular one is narrow. So, and all of them follow suit. So we know it's coming from above the ventricles because we have a P wave and a narrow QRS, and our T wave is going the same direction. Then we have our ST segment here, and it comes right back up to that isoelectric line, so it's fine. And our T wave looks just fine here, nice and round and upright. So I would call this strip sinus rhythm. Okay, so then now you would count your rate. What's your rate? 1, 2, 3, 4. So it's 40. What's your rhythm? So your rhythm is going to go from R wave to R wave. Okay, and with our 40, we know too fast, too slow, or on time. Too slow, so it's bradycardia. And we've got a regular rhythm. Look at your P waves. P wave. Oops, I have to make a little bit bigger mark. P wave. P wave. P wave. So those look fine. They're round and upright. They look the same. The PR interval is unchanged. Next, look at your QRS. Is it narrow or wide? And these all look narrow. So they look good. Your ST segment comes right back up to that isoelectric line. So that looks good. Now, what about your T wave? Your T wave looks fine. So we're happy there. And with your QRS, your P is, you have a P wave, your QRS is narrow, and your T wave is going the same direction. So we know that it's we know that it's not ventricular. It's coming from above the ventricles. There's nothing wrong with this strip except that it's too slow. So I would call it bradycardia. All right, so what's your rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 1, 2, 3, 4, 5, 13, 14. Okay, so 140. Too fast, too slow, or on time? So it's too fast. It's faster than our 60 to 100. What's your rhythm doing? Is it regular? Whoops, sorry. Let me try that again. From here to here to here. That is very hard to do, but it is very regular. Now, what about our P waves? Do we have one? There's a P wave. There's a P wave. There's a P wave. And there's a P wave, and it goes throughout the entire thing. Do we have, they're round and upright, one for every QRS. So we know that that's more than likely a sinus rhythm. They're all coming from the SA node when they look the same. Then you have a narrow QRS and a T wave that's going the same direction. So you know that this rhythm is coming from above the ventricles. Our ST segment, it doesn't go down very far below that isoelectric line. And so that isn't an issue with it hanging out and not coming up very fast, if that makes sense. Then our T wave, nice and round there and going the same direction. We like that. So then you would have to look at your rate. It's 140. We said SVT should be considered at about 150 or above. So 140, I would still call tachycardia, unless you were given a situation where it said this patient was sitting, reading a book, and all of a sudden felt their heart racing, got diaphoretic, clammy, shortness of breath. And when we hooked them up to an ECG, it found that they had a heart rate of 140, and then it immediately stopped. That is SVT. It doesn't ramp up and ramp down like a tachycardic heart rate would if you were exercising or if you were scared. It doesn't have variability. There isn't really any variability in here. It's just running along. So you really would have to start to consider what's the story. But if it was less than 150, I would call it tachycardia. All right, so what's your rate? I've counted 50. Then what's your rhythm? You go from, so then one would hit right about here, and then it would pick back up again here and here. So it's a regular rhythm, except for this here. So we'll address that in just a second. Do we have P waves? Yes, we have P waves. We have one. Whoa, get a little happy there. Right there, and then again after the circle. They look round and upright and the same, and the PR interval is unchanged. So those are nice sinus P waves. So we already know we have a sinus bradycardia. We have sinus P waves, and it's 50 beats per minute. Do we have a narrow QRS? Yes, we do. ST segment looks fine here, and our T waves look beautiful. So then we have to address this circle. What is missing here? We're missing a heartbeat. And so we have this big gap or this big pause. So it'll be called a sinus pause. So I would call this sinus bradycardia with a pause. Sometimes you will hear it called sinus arrest. So sinus bradycardia with sinus arrest. But most people call it a pause. Okay, let me look here for a second. Okay, so you want to see what's your rate. 1, 2, 3, 4, 5, 6. So we're in our 60 to 100. So we're okay there. What is our rhythm? So we have one here to here to here. Would probably be right in here, right? So it looks a little irregular there. So maybe we need to look at our package of P, QRS, and T waves first before we look at our regularity, because right here, it goes back to being very regular. So we want to see if this is an early beat or just an irregularity. So look at your P, QRS, and T all together in this little package. So this P wave right here, does it look the same as this P wave? Nope. Does it look the same as this P wave? Again, nope. But it does look the same as this P wave. So we know that we do have some sinus P waves that are coming through. We have this P wave, doesn't look like any of the others. And this one kind of looks like the second one. So we know that we've got P waves that are coming from different places because they don't look the same. That will make the PR interval change just a little bit. From here to here is a little further. This one's a little closer. This one's a little further out. This one's even further out. So you see how that can change as the P wave changes. Then let's look at our QRS. Our QRS is narrow. Our ST segment comes right back up from that isoelectric line. And our T waves look great. So when you are looking now, you look at all those P waves, they're coming from different directions or different places in the atria. We know that we're probably going to see an irregularity here because when those fire, they fire at different rates. So you will see a little bit of an irregularity right through here. Because those P waves are coming from different areas, I would call this a wandering atrial pacemaker. I don't know why my slide is black. I don't know why that slide is black. That's a very good question. Okay, well, we'll go on to slide 10. Alrighty, so what's your rate? We have 1, 2, 3, 4, 5, 6, 7. So we're in our 60 to 100. So we're good there. What's your rhythm? Go from here to here to here. Looks very regular to me. Okay, and then what are your P waves? Do you have one or before every QRS, or do you have many? I would say you have many. Then you would want to look, so you know it's not sinus, it's not coming from the SA node, but in order to say if it's coming above the ventricles, then I would look and see, yep, I have P waves. Yep, I have a narrow QRS. And yep, my T wave, which is probably this one right here, is going the same direction as my R. So this is coming from above the ventricles. So it is an atrial rate. Then you want to see your ST segment. So I drew an isoelectric line there. Let me continue that line. Your ST segment, it hangs out a little bit. It's not profound. So I don't know. I don't know that I would call it ST segment depression, but it's definitely something I'd want to keep an eye on. And then you have all of these P waves to address. So when you are thinking about those P waves that are coming through, look and see if there's a pattern. So this is regular. Our QRSs are very regular. That's going to tell us something about what's going on here. Then you have all these P waves. Is there a pattern to it? There's two. Whoa, go back. Oh, I got rid of them all. Okay, so here's your P waves. And there are 3 and a QRS and a T. And 1, 2, 3 and a QRS. So there's a bit of a pattern to it. So that will help us in our diagnosis too. Then you want to see if there's anything else that will tell you what this might be. If you look at a saw on the side, then it's looking rather sawtooth. You can see how it's kind of pointy right through here. And it looks kind of like big kind of flutter waves. So I would call this atrial flutter. All right, let's see here. I'm going to look at it for a second. Okay. All right. So what's your rate? You have 3, 4, 5, 6, 7, 8. So you're in your 60 to 100. So we're good there. Not too fast, not too slow. Then what's your rhythm? Go here to here to here to here. So now it looks like we might have an irregularity or a premature beat. So this is what we want to do. We want to back up here a little bit, and we want to look at our PQRST. That's a nice package that looks the same as other PQRS and Ts, and the same as another PQRS and T. But then on this beat right here, it changes. I went right over the top of it, so I'll let you see. Look at the P wave there. Look how it's different than the other PQRS and Ts, because this one goes right back to the way the first one was, and the first and second. And then this one's got a little taller P, so maybe not so much that one, but then this one is kind of funky again. So right here, this is what we're looking at that might be something that needs to take note. So we looked at our regularity, and we're looking like it's a regular rhythm because this beat that is the only one that looks like it doesn't make it irregular by itself. By itself, it comes early. So you've got from here to here to here, and what would have been probably to about here. And so it's an early beat. Then you want to look, we've got our nice sinus P waves here, one before every QRS. We have a narrow QRS, We have ST segments that look just fine. They're not dropping too low or being too high. And our T waves look just fine, going in the same direction as our R. So the only thing that we really have that's wrong is this here, this premature beat. I'm going to get rid of all my lines again. So in our premature beat, do we have a P wave? Yes. Do we have a narrow QRS? Yes. And is our T wave going the same direction as our R? Yes. So that is telling us that that is an atrial contraction. That is not ventricular. So it is a premature atrial contraction. So I would call this sinus rhythm or normal sinus rhythm, whichever, with a premature atrial contraction. All right, so what's your rate? Count all your R waves. So 1, 2, 3, 4, 5, 6, and there might be a 7 right there. But I can't see with my little menu thing. So 6 or 7. We're in our 60 to 100 range, so we're okay there. Not too fast, not too slow. And then we want to look and see what our rhythm is. So we're going along here, here to here, and then we've got something going on here. So to be able to identify our rhythm, we need to back it up and say, okay, this PQRS and T look like this PQRS and T, look like this PQRS and T, and then back to here look the same, and back to here look the same. So that's going to be where our underlying rhythm is. So we're going to say that we have a regular rhythm here. And then a beat should hit about here. And then it's going to pick right back up with our regularity. So here we have an early beat. So first, look at the rest of your lineup. You have a narrow QRS. Your ST segment looks great. Whoops, my line doesn't. Looks, oh my heck. It looks fine. And then your T wave. Oh my gosh, there's a little divot in the wood on my table. Your T wave right here looks fine. And it's going the same direction as your R. So your underlying rhythm is just going to be a sinus rhythm or a normal sinus rhythm. Now you have an early beat and you need to figure out what kind it is. With that early beat, do we have a P wave? No. Is our QRS narrow or wide? It's wide. Is our T wave going the opposite direction of our R wave? Yes. Those three things will tell you it is a ventricular beat. So I would call this sinus rhythm with a ventricular or PVC, a premature ventricular contraction. All right, I'm going to tell you right here that your rate is 180 because then you won't have to count it all. Then you're going to look at your rhythm. It's very, very regular. Then you're going to look at your P waves. Do you have one before every QRS? This might be a P wave, but it's a little bit bigger and rounder. It might be a T wave. So because of the rate, you might not be seeing a P wave. And so then you want to look at your QRS to see if it's atrial or ventricular. Your QRS is very narrow. And your T wave is going the same direction as your R. So it would be safe to say that this is coming from above the ventricles and that it's more of an atrial rate. So it wouldn't be sinus because we can't tell, we can't see those P waves, but we do know that it's coming from above the ventricles. With a rate of 180, let me walk through the rest of it. ST segment. We have a nice ST segment there. Doesn't have any depression. or elevation. And then our T wave right here isn't inverted or isn't peaked. So with this rate being 180 and having it be very regular and having it be above the ventricles, we know that from these other items over here, then I would call it supraventricular tachycardia, or SVT. And that's, oh, no, I take it back. Not it. All right, what's your rate? A little bit hard to count, but we could count here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14, 15, 16. Okay, so 160. So we are cooking. It's going fast. Do we have a very regular rhythm? So here to here to here to here. Or you can count here to here to here to here. It doesn't matter. It's very, very regular. Then we want to look and see if we have any P waves. Do you see any P waves? I don't see P waves. Then how about your QRS right through here? Is it narrow or wide? It is wide. Your QRS here is wide. Then your R wave and your T wave are going opposite directions of each other, R and T. And I'm going upside down because your R wave's usually a little more pointed and your T wave's more rounded. So this is a view that's likely looking at it upside down. But at any rate, if you were unsure, then you could look here and say my QRS is wide. And here my T wave and my R wave are going the opposite direction. So either way, it's very regular. There's no P wave. There's a wide QRS. And the T and R are going opposite directions. That tells you it's ventricular. It's a ventricular beat, and it's going too fast. So this is ventricular tachycardia, or VTAC. All right, so if you were to see these two on a monitor, what would you do? I'm going to make, let's see if I can do this. Make a little text box here and write there you go. Check on your patient. Make sure before you do anything crazy, call a code or whatever, that you go check on your patient. Both of these are ventricular fibrillation. Both of them would require CPR while you're getting a defibrillator and getting the crash cart there. This patient will have no pulse, no blood pressure, no breathing, no level of consciousness, nothing. This patient is dying. It is lethal in 4 to 6 minutes. And so you have to intervene and intervene quickly. But you want to make sure before you call a code and run down the hall that it wasn't a loose lead that a patient was messing with, or whatever the case may be. Oh, and that's it. All right, so the slide that wouldn't show up, I'm guessing, is probably, I think it was 9. Yeah, is probably a fib, because the next one was atrial flutter. So look at your examples of atrial fibrillation in your regular PowerPoint that we did, and any of your practice strips. So hopefully that helps you walk through a few things. I've got those practice strips that are posted, and there are some resources in your book for practice strips. So I will make sure and announce that on Monday about practice strips and about the little cheat sheet I gave you. So if I don't take a minute to address those things, if somebody would jump on their mic and say, please remind us where to find practice strips in our book, and what to do with the cheat sheet, that kind of thing, so that I don't forget. All right, well, I hope you guys have a great weekend, and I'm signing off. Love you, bye.